Detecting Alzheimer disease at an early stage. A clinical case study. In this case study, we show how the AI software AIRAscore can be used to support early diagnosis of neurodegenerative diseases such as Alzheimer disease. Our clinical case shows a 68-year-old female patient who presented to the memory clinic with mild cognitive impairment. But is there evidence in available imaging datasets for dementia? First, we have a look at the regular MR images, without the detailed report generated by AIRAscore. Looking at the images from top to bottom, we observe moderate microangiophatic changes with corresponding signal enhancement in the flare sequence. The ventricles appear to be a bit enlarged, whereas the outer border of the sulcus is still according to age in my view. Moving downwards, we also discover microangiophatic alterations in the region of the pons. The cerebellum appears to be normal. If we specifically focus on the temporal lobe, we do not see any noticeable enlargement of the temporal horns in the axial slices. Let's move on to the sagittal view. Here too, the cortical rim appears well defined. In the mid-sagittal plane, both pons and midbrain are normal. There is no apparent atrophy in the parietal lobe, and the same is true for the contralateral side. Lastly, let us take a look at the coronal slices. Here too, no frontal widening of the sulcus is noticeable. Moving on to the temporal lobe, we can see a well-defined hippocampus bilaterally. The sulcus appears normal, both temporally and parietally. Okay, let us summarize the results of the visual appraisal. We see moderate white matter microangiopathy. The ventricles appear slightly dilated. Frontally and parietally, the cortex does not appear narrowed, nor do we see any widened sulci. Midbrain, pons, and cerebellum also appear normal. And at first glance, the hippocampus does not appear to be pathological. Now, let's take a look at the AIRAscore report. First of all, we can see that we have selected the right patient. We can see the spatial resolution and the sequence parameters. If we now take a look at the individual tissue types, we can see that everything is within the normal range, just as expected. Also, infratentorially, there is no advanced atrophy of midbrain or pons. The cerebellum also is within the normal range. On page 2, we note that the identified widening of the ventricles is still according to age. We are only detecting a minimal upward deviation in comparison to the third and fourth ventricle, which is, however, still within the usual variability of these anatomical regions. Looking at the individual lobes, it is, however, striking that the right temporal lobe, more specifically the gray matter of the right temporal lobe, clearly deviates from the other areas. It appears in the lower color-coded area that is not anymore within the normal range. The hippocampus, which is considered separately from the rest of the temporal lobe, already is conspicuous. It appears in the pathological range bilaterally. Thus, the report indicates abnormalities with incipient cortical atrophy in the right temporal lobe. But also bilaterally in the hippocampus, there is a deviation outside of the normal range, in the sense of a presumable pathological reduction of brain volume in this area. We now have to differentiate between a frontotemporal atrophy, which can, for example, occur in FTD, and, on the other hand, Alzheimer disease. But the involvement of both hippocampi tends to support the diagnosis of early Alzheimer's disease. For any software solution, it is very important to have a good quality control. So we are now verifying the accuracy of the report. We check against the question, are there erroneous segmentations, or is everything segmented correctly? For a quick initial quality check, standardized sections are provided on page 4. These, however, cannot substitute a detailed quality control on the individual planes. Therefore, the software also provides a color-coded overlay on the T1 3D dataset used for the segmentation. Here, we can see the anatomical allocation and are able to confirm that the segmentation of the temporal lobe is correct. We can also see that the hippocampus has been segmented correctly. The same applies for the frontal lobe. We can see the ventricles and also midbrain and pons. We cannot identify an erroneous segmentation, and this is also true for the contralateral side. The same can be said for the tissue maps. Here too, the outer cortex appears well defined. Regions typical for susceptibility artifacts like above the petrous bone show expected thinning. These, however, can also be found in the reference datasets. In conclusion, no relevant erroneous segmentations can be observed. To sum up, we can say that all segmentations were correct. We cannot see erroneous segmentations. The grading in the patient collective is plausible, and therefore, the report appears to be correct. In the initial visual appraisal of the data, we only noted a slight enlargement of the inner subarachnoid space. In addition, there was moderate microangiopathy. The addition of the AI diagnosis demonstrated hippocampal atrophy outside of the age-appropriate range. The same was true for the right-sided temporal lobe, which, taken together, support a suspected diagnosis of early Alzheimer disease. The report thus yields a precise addition to the visual appraisal. It can be interpreted intuitively, and the suspicious findings can be recognized immediately in the summary. The PDF report fits seamlessly into the PACS report and can be easily exported at any time, and the results can be discussed with the patient immediately. If you would like to benefit from brain volumetry, please take a look at our website. There you will find more case reports and also publications that substantiate the added value of the brain volumetry methodology, or just contact us directly.